When psychiatric symptoms worsen before menses, should you adjust the psych meds or treat the premenstrual syndrome directly? Come along as we grapple with the question. Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. We're counting down the top psychopharmacology pearls for female patients. Today, how to manage premenstrual worsening, not just in depression, but across the disorders from ADHD to psychosis. First, a preview of the CME quiz. You'll find the answer in the research update at the end. The FDA recently approved Modius Spiro, the first at-home neuromodulation device for PTSD. How does it work? A. It delivers magnetic pulses directly to the prefrontal cortex. B. It stimulates the vestibular nerve behind the ears with low-level electrical current. C. It uses transcranial direct current stimulation, TDCS, to the temporal lobe. D. It sends electrical signals through the scalp to the amygdala.
Pearl number 4. When menstrual hormones rise and fall, mental health can get shaken. Sometimes you have to address the hormones, and sometimes you need to address the medication.
Last week, we covered the 3 SSRIs with FDA approval for premenstrual dysphoric disorder: fluoxetine, paroxetine, and sertraline. If you go the SSRI route, fluoxetine is a reasonable starting point. Its long half-life means you can stop and start it, dosing only in the 2 weeks before menses, without significant withdrawal, since the drug lingers in the system for about 6 weeks after stopping it.
But wait, thoughtful listeners might rightly ask, doesn't that long half-life also mean that fluoxetine takes much longer to reach steady state and to work? Yes, but this doesn't matter like you'd think. You'll sometimes hear that fluoxetine has a slower onset of action than other SSRIs because it takes longer to reach steady state. But that is a theory, no fact behind it. In clinical trials, fluoxetine takes effect at the same steady pace as other SSRIs. I guess the brain doesn't need round-the-clock fluoxetine coverage to treat depression, any more than a garden needs constant watering to grow. Plants actually do worse when we water them all day long. The roots get soggy and they mold. And, on the medication side, lithium is safer for the kidneys when they get a little reprieve from the levels by dosing it all at night instead of twice a day. So why should we assume that the brain needs a constant flow of medication for the medication to work?
SSRIs have FDA approval for premenstrual dysphoria, but they're not the only option, and they're not safe in bipolar. Another way to address premenstrual dysphoria is through natural therapies. Last night, Dr. Aiken just turned in what he hopes is his final manuscript on the upcoming Carlat Complementary and Alternative Medicine Psychiatry Fact Book. In it, he sorted through around 2,000 randomized trials to rank each one by the quality of the evidence.
And if the treatment worked in at least 2 large randomized trials, I gave it the top rating, confirmed. That's in line with what the FDA requires for approval, at least what they used to require. While I was writing this book, the FDA lowered their standard to 1 trial instead of 2, but I'm old school.
Okay, only 1 supplement earned Dr. Aiken's approval for premenstrual syndromes, Chasteberry, which is backed by 9 large and 3 small placebo-controlled trials in premenstrual syndrome, where it improved irritability, sleep, mood swings, headache, bloating, and breast pain. But it's a little better for physical pain than mental symptoms. Moving down a step where the trials are smaller, these earn a probably effective rating, so the evidence is decent, kind of like when you use medications off-label. They are omega-3 fatty acids, zinc, calcium, and ginkgo. 11 other treatments earn a possible rating based on smaller studies, and these are rarely worth using, so we won't mention them here.
But whether a treatment is likely to work depends on the patient. So we can also personalize this by checking blood levels in premenstrual syndrome, not of hormones, but of iron and vitamin D. Those are the two with the highest yield here. Iron is often low in menstruating women, and correcting it improves mood and fatigue. Vitamin D has a more specific link to premenstrual dysphoria. This nutrient was tested in premenstrual dysphoria, and it worked, but only when levels were low. L-methylfolate may also work in premenstrual syndrome. It hasn't been tested there, but we know that abnormal folate metabolism genes, the MTHFR ones, double the risk of developing premenstrual dysphoria.
What about vitamin B6? I often see that one used for premenstrual dysphoria.
Yeah, that one has an interesting history. In the 1970s, vitamin B6 was promoted for women's health and menstrual symptoms in the groundbreaking book, Our Bodies, Ourselves. The book was an instructional manifesto urging women to take control of their own health care in a male-dominated medical world. The impact was profound, and it helped move the field from paternalism to more collaborative care. But there are risks on both sides of that balance, as the vitamin B6 story shows. The early editions of the book encouraged vitamin B6 almost like a blanket therapy for premenstrual symptoms, and some women started taking more and more of it. Then in the 1980s, case reports came out of neuropathy on high-dose vitamin B6, mostly in women who were taking it based on the book. Doctors were quick to pounce on this wayward vitamin, and the book, Our Bodies, Ourselves, toned down their recommendations. Here's where the research stands today. Vitamin B6 has 11 randomized trials in premenstrual syndromes, and although only 45% of them were positive, it did pass in a meta-analysis. Now, that's actually better than the FDA's scorecard for Gepirone, which they just approved for depression after it worked in 15% of the trials. But to me, the glass is only half full on the vitamin B6 question, so I gave it a lower rating in the book of possible for premenstrual syndrome, which is a word I'm using to refer to both the physical and the psychological symptoms that go along during the premenstrual phase.
But the story doesn't end there. There's emerging evidence that we can avoid this neuropathy risk by using the active form of vitamin B6 instead of the synthetic pyridoxine, kind of like how we use methylfolate instead of folic acid. One of my favorite parts about the book was the new research on using vitamin B6 to reduce antipsychotic side effects like high prolactin, akathisia, EPS, tremor, and possibly tardive dyskinesia.
We could probably write a whole book on menstrual changes and psychiatric treatment because it's so relevant to patients, but this would be a very hard book to write because the research here is unfortunately so thin. Many women, for example, say that ADHD worsens before their menstrual cycle, and observational studies do confirm this, but there are no treatment studies to tell us what to do. And it's intuitive to raise the stimulant in the 2 weeks before menses, but that also carries cardiac and psychiatric risks. On the other hand, hormonal therapies might be a better option for these women with ADHD, or maybe some of the CAM therapies that we mentioned above. We really don't know. There are some natural therapies that improve both ADHD and premenstrual syndrome, and I would consider those as well, like zinc, omega-3 fatty acids, and one that improves cognition, not ADHD, but cognition, and the premenstrual syndrome, that's ginkgo. Now, if your patient says their psychiatric symptoms, whatever they are, worsen before their menstrual cycle, don't just assume that it's the psychiatric disorder that's getting worse here. It could be the premenstrual syndrome. So ask about those symptoms, both the physical and mental ones, that we know happen during this syndrome.
On the psychological side, there's mood swings, irritability, tearfulness, anxiety, insomnia, fatigue. On the physical side, hot flushes, night sweats, palpitations, bloating, food cravings, joint pain, breast tenderness, vaginal dryness, pain on intercourse, and urinary frequency or urgency.
Around 40% of women with ADHD have premenstrual dysphoric disorder. Those symptoms are distracting in themselves and are treatable with either oral contraceptives, SSRIs, chasteberry, like we mentioned, omega-3 fatty acids, zinc, and ginkgo. So you may not need to raise the stimulant for all women. You might treat an underlying premenstrual syndrome, but a lot of how you go about this is going to depend on which symptoms are at play and whether they're psychological or physical.
What about bupropion?
Bupropion helps ADHD a little, but it doesn't help premenstrual symptoms. It failed in the only randomized trial there that tested it in premenstrual dysphoric disorder.
Most psychiatric disorders can worsen in the 2 weeks before menses. Depression, bipolar, borderline personality, psychosis, ADHD, OCD, and anxiety disorders, including PTSD. Also, binge eating and bulimia, because premenstrual hormonal changes cause food cravings. Alcohol use rises too, though we don't know much about other substances. The cause of all this premenstrual worsening is poorly understood, but likely involves heightened sensitivity to normal fluctuations in estrogen and progesterone, which have downstream effects on serotonin and GABA. And for most disorders, the treatment is unclear. Should you treat the underlying psych disorder or treat the premenstrual syndrome? In depression, we often raise the serotonergic antidepressant, as that addresses both problems. But outside of depression, we don't know which, if any, of these roads to take.
A large study from Sweden that was published just last May gives us a clue. The design is a little complex, so let's start with the bottom line. Premenstrual syndrome causes psychiatric disorders to worsen. On the other hand, having a psychiatric disorder causes people to have more premenstrual syndromes. The causes are bidirectional, each one roughly doubling the risk of the other. That means that you may be able to make a difference on either end, with one exception that we'll get to: schizophrenia. The study was huge. They followed psychiatric and premenstrual symptoms in just over 100,000 women for 8 years. For a comparison group, they used a case control design where psychiatric patients were matched with similar healthy controls, and they were also matched with their own biological siblings to account for some shared genetics and environment.
They found this bidirectional causation held up for nearly all psychiatric disorders: bipolar disorder, depression, anxiety disorders, ADHD, and personality disorders. The one exception was schizophrenia, where premenstrual syndromes did not predict psychotic worsening. Schizophrenia does tend to worsen before menses. It's just that this worsening is not connected to any premenstrual symptoms. Why is schizophrenia the lone exception? The authors speculated that psychotic symptoms may be so florid that we miss the more subtle premenstrual ones, so the link may still exist. But I'd at least avoid chasteberry in psychotic disorders. It can raise dopamine, and there's a case report of psychosis on it. Pearl number 5. Oral contraceptives affect mood in younger women.
There's a paradox with prescription hormones. Estrogen can improve mood during perimenopause, when hormone levels are falling. But on the other hand, estrogen can worsen mood in younger women who have normal estrogen levels when it is given as an oral contraceptive. The risk here is small, and here's who you need to look for. Teens are more vulnerable to it, and so are women who've had painful menses or have had a history of perinatal depression. And some oral contraceptives carry more risk of mood worsening than others.
The oral contraceptives that are least likely to disrupt mood are those containing drospirenone and ethinyl estradiol. Yaz and Yasmin are the common brands. This is a lot to remember, so here's a mnemonic. Say yes to Yaz and Yasmin. Intrauterine devices are also lower risk because they deliver much smaller doses of hormones. The contraceptives with the greater risk of worsening mood are triphasic preparations, where hormone levels fluctuate across the cycle, and also the progestin-only formulations. Progesterone is more destabilizing. Here's a practical option for women who want to reduce premenstrual mood symptoms while taking oral contraceptives. The OBGYN can extend the cycle by skipping the placebo week. With this strategy, the patient will menstruate every 6 months instead of monthly. This smooths out the hormonal swings that drive premenstrual symptoms, both physical and emotional ones.
Another option for women whose mood gets worse on an oral contraceptive is a little off the beaten path here. It's lavender oil, which is marketed as Silexin. It's a prescription medication for generalized anxiety in Germany and other countries. Lavender modulates glutamate and serotonin. Many of our listeners know of lavender for its large effect in anxiety. It's also the only, quote, medication I know of that improves mood symptoms caused by oral contraceptives in a controlled trial. The study here was small, 60 women aged 15 to 49, but the idea of lavender helping is backed up by large studies in anxiety and depression. The dose for anxiety is 160 milligrams a day, usually given twice a day. But for mood symptoms on oral contraceptives, they used 80 milligrams a day. That's the same dose they used in depression studies of lavender. Lavender is well tolerated, with lavender-flavored burps the main side effect. In the U.S., it's available as Calm Aid by Nature's Way, which uses the same patented extract available by prescription in Europe. People sometimes ask me why I'm interested in natural therapies. I'm really not interested in them for their own sake. I'm just interested in getting patients to full recovery, and medications alone don't get them there enough. Most disorders have full recovery rates around 30% with meds, and rotating meds doesn't move those recovery rates much further. So I just believe in using all options: therapy, lifestyle change, neuromodulation, ECT, and natural supplements. Sometimes the non-pharmacologic pathways are more effective than medications, and in the case of neuromodulation and ECT, it's almost always more effective.
But are there supplements that have an edge over medications?
Most of them do for tolerability, and some have additional medical benefits, but in terms of actually beating out meds on efficacy, that's a short list. There's Lightbox for depression, lavender for generalized anxiety disorder, ginkgo in vascular depression, that's hard to treat with meds, and zinc in anorexia where otherwise meds don't work, and, maybe a few more. It's a tough call, and it depends on the patient. Like, if they have a folate deficiency, then methylfolate might be more effective than an SSRI for their depression.
Number 6, watch for drug interactions with contraceptives.
Estrogen-containing contraceptives lower lamotrigine levels significantly. We're talking by 30 to 50%. Hormonal replacement therapy lowers lamotrigine too, but to a lesser degree. For most people, lamotrigine maxes out around 200 milligrams a day in bipolar disorder. Studies have compared 200 milligrams to higher doses, but it didn't make any difference for bipolar depression to go higher. But for women on oral contraceptives, they are an exception where you may need to push lamotrigine to 300 or 400 milligrams a day.
What about middle-aged women on hormone replacement therapy, HRT? Should you push it there?
HRT doesn't lower lamotrigine very much, so raising the dose there is optional, and I usually don't because of their age. Older adults tend to respond to lower doses of lamotrigine by about 15% lower, and are more sensitive to its side effects, especially cognitive ones. So I'll usually stick in the 100 to 150 milligram a day range for patients who are over 60. If they're on HRT, I may push that to 200 milligrams a day, but usually not higher. Oh, and don't forget about pregnancy. lamotrigine levels fall 30 to 50% in the third trimester of pregnancy, about the same drop that you see with oral contraceptives.
But this contraceptive interaction doesn't go the other way. There's a myth that lamotrigine lowers oral contraceptive levels. There's no evidence for that, but several psychiatric medications do lower oral contraceptive and HRT levels. Carbamazepine is the most potent, followed by oxcarbazepine, topiramate, the modafinils, and St. John's wort. These drugs induce CYP3A4, accelerating estrogen's clearance. If you prescribe any of them, recommend another method of contraception, like condoms or barrier contraception. Transdermal and implant formulations of contraceptives bypass this interaction, but only partially, so the risk is still there. Today's research update covers an unpublished study that led to a new FDA approval. On May 26, 2026, the FDA approved the first at-home neuromodulation device for PTSD. The device is called Modius Spiro, made by Neurovalens, the same company behind a similar device for insomnia. This is an approval, not just a clearance.
Modius Spiro is the third at-home neuromodulation device approved in the past year, following Flow, a TDCS device for depression, and ProlivRx for depression that has failed an antidepressant. Jog back to our January episodes for more on those. Modius Spiro resembles ProlivRx in that it stimulates cranial nerves rather than stimulating the brain directly. It delivers low-level electrical current to the skin behind the ears, activating the vestibular cranial nerve. That's the nerve that handles balance and position. The signal then travels to the brainstem and hypothalamus, areas that regulate sleep, circadian rhythms, and the stress response.
The trial behind the approval was a randomized, sham-controlled study of 383 adults over 12 weeks. Patients wore the headset 30 minutes daily. Reportedly, 2/3 had a meaningful improvement, but the trial hasn't been published yet, so we can't say anything about its validity. The study was funded by Neurovalens, the manufacturer. Modius Spiro is approved for adults 22 and older. Starting in July, it should be available by prescription through the VA health system. VA clinicians can sign up on the Neurovalens website. Outside the VA, access is unclear. The retail cost is just over $2,000.
Special thanks to Owen Muir of the Frontier Psychiatrist Substack blog, who alerted us to this story.
Dr. Aiken posts brief research updates on his blog. Go to chrisaikenmd.com and click on Research Updates, or in the menu, click Learn. If you're short on time, filter the list to just the top studies and join the conversation on social media. Search Chris Aiken MD on LinkedIn, Twitter, Facebook, Blue Sky, or Threads.